Welcome everyone to the next Optimising Outcome webinar, and this one follows on from some questions we had in the last one about flexion. So we're going to be discussing in a little more detail today the effect of flexion above the prosthesis on amputee gait and prosthetic performance. Just a quick reminder that the aims of this series of webinars are to provide practitioners with techniques to enable their clients to gain improved functioning on their prosthesis and to facilitate communication between physios and prosthetists mainly regarding training goals and techniques which will help their amputee clients improve on their prosthesis. Because generally, in my experience, the prosthetist tends to look down on the prosthesis and what's happening there. The physios are looking above the prosthesis and what's happening there. And this series of webinars is designed to bring those two sets of eyes together to meld into one and produce a single direction for the treatment of the amputee client. These webinars are looking at clients in the low to moderate activity category, and they would include your primary amputees walking on for the first time on their prosthesis, elderly amputees, those in the K1 and K2 classification, those using their prosthesis for transferring, mobilising around the home, and for amputees using walking aids, because walking aids can have, or the way you use a walking aid, can have a significant effect on the amputee gait, as we'll see later in the webinar. The actual amputation will affect muscle function in a couple of ways. Firstly, some muscles will become inhibited and weak, and other muscles will become overactive and tight. This is due to the pain of the surgery and the pain in the stump after the surgery, the actual surgery and which muscles are cut and not cut, positioning pre and post-operatively, and adopted movement patterns which happen after the amputation as well. We'll be looking at all those things in a little bit more detail right now. If we look at the issue of positioning, this happens way before the amputation actually does. Amputees will have some sort of issue with the leg to be amputated prior to the amputation, and that can be months in coming before they actually undergo an amputation. So we're looking at someone who's traditionally positioning the leg in elevation so that the hips are already in flexion, there's flexion of the knee, and if we look where the hip extensors are, the extensors are becoming lengthened on the underside of the leg there. Once the amputation occurs, these positions are again reinforced as the amputee is sitting in a chair, so the hip is even further flexed at 90 degrees, and the hip is even extended more in extension. Now, prolonged positioning, as we know, has effect on the muscle's ability to develop tension. So a muscle that is lengthened beyond its optimal length will have difficulty in producing tension, as you can see here on the left, on the length-tension relationship of muscle. And on the right-hand side of the slide, we're dealing with the opposite muscle, or the agonist, which are the flexors, and they will have less range, less slack in the muscle, and earlier shortening because they are in a shortened position initially. These muscles will then undergo a greater afferent input because every time they move, they receive a stretch reflex to their stretch receptors at the spinal cord level. So we're really doing a stretch reflex on these muscles, which makes them contract much more strongly and gives them much greater input. And lastly, we know that the neuromuscular system is plastic. You've all heard of the neuroplasticity idea, so that the more we activate a neuromuscular system, the stronger it will become. And this happens when we start to strengthen systems within the first 2 weeks of doing a new movement pattern. So if we're starting to bombard the flexors with afferent input, that system is going to become stronger and easier for the amputee to activate, and the antagonist, which is the extensors, are going to be much harder for the amputee to activate because they're receiving less afferent input. Amputation also affects muscle function by simple anatomy of the amputation. If we have a look at the system on the left, we can see that the hip flexors insert high up onto the femur. The extensors, however, on the right, insert all the way down the femur, the hamstrings even crossing the knee joint, and so those muscle insertions are cut, which will affect that muscle's ability to generate tension and strength when the amputee tries to activate and use them. So they will be inhibited a bit by pain and also having less insertion on the bone to act with. So we have flexors that are unaffected and nice and strong, and extensors that are affected and weakened a little bit. So we've got a bias there surgically towards the flexors, away from the extensors, particularly in the case of the transfemoral amputees. Amputation also affects movement of the amputee by affecting core stability. There is a predisposition towards anterior pelvic tilt in the sagittal plane and hip flexion. This is carried out because of a decreased ability of stabilisation of the pelvis by the hamstrings, those tight and overactive psoas muscles, the weakened and lengthened abdominal muscles, and the weakened and lengthened gluteals. This is demonstrated much better by this slide. On the left-hand side, you can see the pre-amputation condition in standing in weight bearing when the pelvis is in a neutral position. So the ASIS and the PSIS are virtually in a line through S2. The pubic bone directly under the ASIS and the pelvis in the neutral position. And it's held there by a fine muscle balance of all the muscles acting around that pelvic hip complex. Now I've documented those on the right-hand side in the slide, and the arrows will be showing the areas of activation and deactivation. The deactivated muscles are shown in yellow. So we can see that the yellow arrow down the bottom here is a decreased activity of the hip extensors and the hamstrings. Now we know that the primary action of the hamstrings is actually to aid in pelvic stabilisation during weight bearing, not just flexion of the knee joint. So there's a very important action of the hamstrings, which quite often goes unrecognised in the case of the transfemoral amputee. So they have a much less ability to stabilise this anterior tilt of the pelvis in that direction because they have a weakened pull by their hamstrings. So as the pelvis is tilting anteriorly, we've got a stronger pull by the iliopsoas muscles down on the anterior aspect of the pelvis and the hip joint. So we've got an increase in hip flexion. This means that our abdominal muscles are lengthened and thus weakened in the abdomen on the anterior side of the pelvis. And in the back, the erector spinae muscles are shortened, tightened, and become stronger, pulling the pelvis upwards in this direction, and so increasing that likelihood towards anterior pelvic tilt. So we have a whole lot of systems working to tilt that pelvis anteriorly, particularly in the transfemoral amputee, particularly when they're weight bearing in a socket. So we need to consider these things in our training and our fitting of transfemoral amputees. So effectively what we have is someone who is learning motor patterns in a new way. Their neuromuscular system is plastic, and it's learning that every time they move, they're going to flex this hip joint and hold the stump in flexion. Now you can imagine by gravity acting on that stump and pulling down slightly, it's giving this tight psoas muscle that afferent input and a little stretch reflex and increasing the flexion in that hip joint. And on the antagonist side, the extensors, they're becoming lengthened and less used and weaker. So when we actually apply a prosthesis to the amputee, when their brain is telling them to walk and move, their muscle system is going down that highway of flexion that has now developed over weeks and months, remember, prior to the amputation, and then after the amputation prior to prosthetic fitting. And they're going to have difficulty in getting these extensors to work, which are the primary muscles that we want to work during amputee gait. And so we're going to look at ways to improve the functioning of these muscles and inhibiting the function of the flexors in amputee rehabilitation. So we have the situation here after amputation where muscle imbalances are created. Some of these muscle imbalances, as we've mentioned, are length-related, and they will then become associated with joint restriction and be present in the condition of joint contracture. And that's where we get contracture and stiffness of the joint capsule and ligaments themselves, as well as restriction of the muscle. We get related muscle imbalances related to preferred activation patterns. Remember those neuroplastic superhighways that have just been instigated. So the amputee has learnt to use a different motor pattern than the one they need to for good amputee walking. And these muscle imbalances will then be reflected in the gait pattern in the form of gait deviations. The next couple of slides I'm going to be talking about the concepts of pelvic tilt and pelvic rotation. And this slide is just to clear up those two concepts for you. As I mentioned initially, pelvic tilt occurs in the sagittal plane, so it's tilting of the pelvis forward so that the hip will tend to hip flexion from the neutral pelvis, where it's straight up and down, to a pelvis that's tilted forwards with an increased lumbar lordosis and an increase in hip flexion on the anterior aspect of the body. The other concept is pelvic rotation, which happens normally during gait in the transverse plane and happens in the direction of the stance leg. So as we come over the stance leg, pelvic rotation happens posteriorly to about 6 degrees, but in the amputee, it's much more magnified, and so we get an excessive amount of pelvic rotation posteriorly in this direction, and it's a bit like a pelvic twist backwards towards the side of the stance leg. So we don't want to confuse those two concepts as we move forward to these slides. Now, this slide is representing the situation of prosthetic stance phase in someone who has inadequate hip extension and excessive posterior pelvic rotation in the transverse plane. The diagram represents someone who's walking with an optimal walking pattern. So I'm going to ask you to use your imagination a little where the yellow arrows are occurring that are showing you what would happen in the adverse situation of inadequate hip extension and excessive posterior pelvic rotation. So firstly, when we have hip flexion and a posterior pelvic rotation in that direction, we will usually have a flexed trunk as well. We have flexion of the stump, and so our weight line falls down behind the knee joint and we have compromised knee stability. We will have a hip joint that is low and posterior to the prosthesis, as we can see here. And so the prosthesis will be effectively lengthened for the amputee. Therefore, they will only be able to take a shortened step with the intact leg Remember, the pelvis is actually moving backwards, not forwards. So they can't move onto their prosthetic toe properly. They take a shortened step with their intact leg, which means they're going to come off their prosthetic foot early at around the level of the midfoot, maybe reaching the metatarsal level, but probably not. So they're going to go into a premature prosthetic swing phase, which means they're going to have difficulty in breaking that knee joint into flexion, and they're also going to have difficulty in clearing that prosthesis during swing phase. And in all likelihood, your patient is going to say to you, my prosthesis is too long, can you make it shorter? Because they're finding the knee hard to break and they're dragging the foot along the ground. Now we're going to move to the situation of having adequate hip extension because we've stretched and trained it, and we'll talk about that later in the webinar, and pelvic rotation, which is limited in the posterior direction and hopefully will be producing an anterior pelvic rotation force. So here we've got someone who can generate an extension force by using their gluteals actively and strongly, combined with someone who can maintain an erect trunk through abdominal activity and core stability. This will ensure that the weight-bearing line falls down through the knee joint or in front, giving us knee stability. The prosthetic hip on that side during stance is in a high and forward position, because remember that pelvis is coming forwards, not rotating backwards. So the ability of the amputee to take an equal step with their intact leg is maximised. They are able to move further forwards onto the prosthetic foot, reaching the prosthetic toe, which means that the hip has remained high and anterior during their gait. They will then be able to break that knee with greater ease, and the hip is high, so the prosthesis will swing through and clear the ground easily. Foot clearance is achieved, the prosthesis has not been effectively lengthened, and you'll have an amputee who can walk to the correct length of their prosthesis. Now, this idea was borne out in a study by Ignacio Glenard and Robert Gailey in 2011, where they looked at 43 transfemoral amputees, and they were looking for equal limb length versus a shortened prosthetic limb length. They found that although all of their transfemoral amputees had some degree of hip extension on the prosthetic side, those who had a shortened prosthetic limb had a greater degree of hip extension restriction on the prosthetic side. So we can gain from this that problems with extending that hip and having fixed flexion on the prosthetic side is going to lead to those gait problems and problems with clearing the prosthetic limb during swing, leading to the client wanting a shortened prosthetic limb. And we know that if we shorten the prosthesis excessively, that's going to predispose to back problems and arthritis of the lumbar spine. So we do want to try and limit the degree to which we shorten the prosthesis. Now we're actually going to look at some pictures of how muscle imbalances are reflected in amputee gait. So in the photo on the left-hand side, you can see that throughout the prosthetic stance, he's coming to the end of prosthetic stance here, he's still got a very flexed hip where we would like that to be in almost full extension. He's got posterior rotation of the pelvis. You can see that it's rotated posteriorly. So his hip joint is not only flexed, it's placed posterior to where we want it to be. We want it to be forwards about here. He's only able to take a decreased intact step length. He's dropped off his prosthetic toe in knee flexion as well because he hasn't been able to get that hip forwards. And his hip extensors are in a very lengthened position there. So they're in a position where they're not going to be able to contract strongly and extend that hip and bring that pelvis forwards to get a better step length and forward progression onto the intact leg. So where is all this excess flexion coming from? We need to pin it down a little bit more than to just it's coming from above the leg. We want to look at whether it's coming from the joint, coming from the muscle. Is it anatomically based or is it performance based by the amputee? So we're looking here on the left-hand side at checking for joint range of movement to see if it's the anatomy of the person that's stopping that extension on the amputated side, or on the right-hand side whether they're actually doing something in their performance that needs modifying, as he's doing here in placing his sticks too anteriorly, and that's causing excessive flexion on the prosthetic side. And we're going to move on now and look at that in a little more detail. So first of all, we're going to look at the range of movement of the hip on the amputated side. If we lie the amputee prone, we can see on the left-hand side here in someone who might have a flexed contracture of their hip, they're actually unable to lie on the bed with a nice flat pelvis, as we can see here on the right, with a fully extended hip. So in someone who has a fixed flexion contracture of the hip on the amputated side, the pelvis will be posteriorly rotated, the hip joint will be elevated off the bed, and if you palpate their ASIS, or the anterior superior iliac spine, it will be up here off the bed rather than down here in contact with the bed in the unrestricted side. And importantly, there will also be an increase in their lumbar spine extension, as we can see here with the blue arrow, versus a nice neutral spine position on the side where there is no restriction in the hip joint on the amputated side. So we're looking at a neutral lumbar spine position there, ASIS on the bed, and stump straight down in an extended position. If we're going to assess their passive range of movement, the passive range of movement is actually looking at the amount of movement of the joint and whether there's restriction around the joint, and this could be restriction due to a tight hip capsule, perhaps tight ligaments, or those shortened, tightened muscles. Here we're looking at the transtibial amputee performing Thomas's test. We get the amputee to pull up on their intact leg, knee towards the chest as hard as they can to try and stabilise the pelvis down in a neutral position against the plinth, while the tester produces a force down on the amputated limb to test range of movement of the hip here. And for the transtibial amputee, I'm also producing a force to flex the knee slightly, remembering that the rectus femoris crosses the hip and the knee joint, so we need to be able to not only extend the hip, but also flex the knee at the same time and keep the hip extended to make sure that there's adequate range of movement to get a nice prosthetic stance on that transtibial side. For the transfemoral amputee, again, pulling up on the intact leg, pulling down towards the chest to stabilise the pelvis, flat on the bed, while the tester produces a force in the downward direction, getting the stump down towards the bed. And we're looking at trying to get a stump in full extension along that sort of line there. So he's possibly got a very slight amount of restriction there, but certainly I wouldn't say that he's got a hip flexion contracture as such. So that's someone with a good range of hip extension for a transfemoral amputee in a passive way. Now we have to look at the amputee's ability to move their own stump through that joint range. So we're looking at active hip range of movement. So can they use the available joint range of movement in an active way? So we're looking at trying to isolate the gluteal muscles and their ability to extend the stump off the bed while maintaining a neutral spine and pelvis, and ASIS clamped down onto the bed. So the instructions that we would use are push that bone down into the bed, and they do that by contracting their abdominals, and then lift the stump backwards up off the bed. And really it's a very small movement. We're only going to get a little bit of movement of the stump off the bed by using the gluteal muscles, and a therapist or prosthetist can palpate the gluteal muscles and feel the contraction working there. On the right-hand side, you can see that the exercise is being performed in an incorrect manner because he's using his lumbar spine extensors. He's got an increase in lumbar spine, lordosis there, and extension. He's elevated his stump excessively off the bed, and you can see that his ASIS has moved well and truly off his hand and up off the bed. So he's not actually using purely the gluteal muscles in an isolated way, which is something we want to avoid when they're walking, because if you can imagine he's walking here, he's actually posteriorly rotating his pelvis. On this side, he's trying to produce an anterior pelvic rotation force to keep the pelvis down on the bed while he's elevating the stump in the opposite direction. And that's walking, and I'll quite often use that as a very initial walking exercise as well for the physiotherapists. So we've talked quite a bit about the above knee amputee walking gait. We're going to have a look now at the transtibial amputee who has a flexed gait pattern. And that's reflected in terms of prosthetic stance with hip and knee flexion occurring at the same time, because that superhighway of flexion has been produced over that long period of time. So he's weight bearing through the leg, and he's really forgotten how to activate his hip extensors and knee extensors at the same time. So he's just lazily rolling over the prosthesis with the hip joint moving posteriorly and the knee joint moving anteriorly into flexion and lowering on that side, really basically limping over the prosthesis. So what we need to do is retrain extension of the hip joint and knee joint together. We need to have a synergy between the gluteals and the quadriceps to produce extension of the hip and extension of the knee as the amputee pushes himself over the prosthesis. So you can see here the pelvis or the hip joint is high and anterior, and he's pushing in an anterior direction with his gluteal, and with his quadriceps he's pushing in a posterior direction. And sometimes that can be quite a difficult concept for the transtibial amputee to grasp, pushing forward with the pelvis while they're pushing backwards with the knee. And that's what we're retraining with the transtibial amputee who has problems with flexion above the prosthesis. Further extension training can be done with a small step and stepping up with the prosthesis, because to step up onto that step he's going to have to extend his hip and his knee even more strongly, and also extend his trunk in an upward direction. So we're really going to come forwards here from the hip, backwards from the knee to stand up straight onto that step, to produce someone who can now extend through that prosthetic side with the hip and the knee, the glutes and the quads working together against firm abdominals to produce a really good step length with the intact leg. and an even step pattern. While we're focusing on flexion problems with transtibial amputees, we're going to have a look at the fine knee control that needs to be trained in terms of concentric and eccentric flexion extension training for the transtibial amputee. And I'd use this type of exercise where we're weight bearing through the toe, we have a TheraBand position behind the knee joint, and he's just going to flex and extend that knee strongly off the prosthetic toe. This is for someone who has that wobbling knee joint during prosthetic stance phase where they start to weight bear on the knee and that knee wobbles a bit forwards and backwards in the anterior-posterior plane. We've got someone with an inability to control the power from an energy returning foot. We're trying to give somebody better control of the knee on slope and stair descent. So remembering that as we come down slopes, there is an increased flexion moment around the knee. So this exercise is trying to get them controlling that knee into extension while they're coming forwards onto their toe. Or we're looking at someone who's progressing onto a foot with a stronger toe lever. So it may be someone who started off on a balanced foot, they've progressed through their rehab, they're becoming more active, maybe they've gotten back to regular walking or perhaps golf, and they want a little more active foot. This exercise will help move them on to a Veriflex or some other foot with a stronger toe lever so that they'll basically, what I like to term, get more bounce to the ounce out of their prosthesis and really start to appreciate the toe lever on the end of their flex foot. I'm now going to move on to looking at the influence of walking aids on amputee gait in terms of flexion above the prosthesis. Now, if we look at walking with frames, frames can increase flexion for the amputee at the trunk and the hip if we have the height of the frame too low. This looks to be an optimal height for this lady because she's got a nice extended hip joints and a nice extended trunk. So she'll be able to walk with a little bit of power with her frame. And remember that if someone's a transtibial amputee, we're relying on hip extension to assist in maintenance of knee safety. So we do want them to be in a position of hip extension and trunk extension. So height of the frame is important. We want to avoid overstepping into the frame with the prosthesis, because then when they bring their intact leg into the frame as well, they'll be prone to overbalancing backwards. So we don't want to take a great big step with the prosthesis, remembering that that is something that primary amputees often do because they're overactivating their hip flexors and they want to take a bigger step with the prosthesis. We need to limit that step length. When using frames, we want to try stepping off into the frame with the intact leg, meaning we'll be using extension of the prosthetic leg while we're standing on that and swinging the intact leg forward. The frame should not encourage excessive trunk flexion and hip flexion. And we want to keep up our range of movement stretches and exercises in case this person is going to progress further from the step 2 gait pattern, which is encouraged with the frame. So because we don't have room to do a step through gait pattern, we're going to do a step 2 gait pattern. We want to maintain that ability of the amputee, it wants to go to that slide, to have a step through gait pattern should they progress from a frame onto perhaps crutches or sticks. If we're looking at someone walking with sticks, if the sticks are placed too far forward of the prosthesis, trunk and hip flexion is going to be encouraged, as we can see here. So he's placed his sticks too far forward, the hip is flexed, the trunk is flexed. And we saw from those earlier slides, If that happens, the hip on the prosthetic side is low and posteriorly situated. The prosthesis becomes functionally lengthened. He will have difficulty in breaking that knee joint for swing phase. He'll have problems with toe clearance because he's going to try and come off that prosthesis too soon, and he will want the prosthesis shortened because he won't clear his toe easily during swing phase. What we need is the sticks to be placed correctly at the level where the metatarsal heads would be on the prosthetic foot, so he can weight bear right to the end of his prosthetic foot. Weight is transferred from the heel to the front of the prosthetic foot. Mechanical advantage of the hip on that side is achieved. The position of the hip is high and forwards. He's got anterior pelvic rotation happening there. It facilitates breaking of the knee joint and clearance of the prosthesis during swing phase, and an even step length can be achieved with the intact leg. So very important to place the sticks in the correct position. So the implications for all of these terms of flexion above the prosthesis are, in the clinic, can we actually walk flexion out of a flex joint? Yes, we can, is the answer, but it needs attack from both sides. It needs an attack from the prosthetist in not accommodating the full amount of hip flexion in the prosthesis. So we might be looking at leaving, say, the last 5 degrees out of the prosthesis, and then the physiotherapist will introduce a program of postural re-education, stretching program, extension exercises, and gait re-education to integrate the improved activation of the hip and core muscles into the gait pattern and the correct use of aids when the amputee is walking. It requires commitment from the amputee in that they will need to attend physiotherapy at very least once a week to make sure they're able to carry out these exercises and improve gait pattern correctly. We need to reduce the socket flexion or the flexion within the prosthesis gradually to avoid back pain from excessive lumbar spine hyperextension. And we need to realise that the longer the hip joint restriction has been evident, the harder it will be to resolve for the amputee. So typically we might find that someone has some sort of incident where they've been admitted to hospital, they've been off their prosthesis for a while, and they've developed a little bit of hip joint restriction on the prosthetic side. If we leave that flexion out of their prosthesis, if we don't accommodate it, we are going to be able to walk that flexion out by a program of stretches, exercises and gait training to maintain or regain that hip range of movement. So putting that into pictures, we can see that it's very common for someone with a transfemoral or even transtibial amputation to want to stand with their prosthetic foot forwards a little bit to keep some weight off the prosthesis. This, however, produces an unstable knee with their flexed hip. So when they place their heel forwards, their weight-bearing line is going to fall posterior to the knee, and it's going to create an unstable knee with that flexed hip. What we need to do as therapists and prosthetists is remind the amputee that they need to stand with a correct posture, which means their foot placed directly underneath them with the hip in an extended position so their weight line can fall through that knee joint or slightly in front of that knee joint where the knee will be in a safe position with an extended hip. Our hip flexor stretches should be beginning as soon as possible after amputation, and it's going to mean lying prone on the bed for the amputee with some sort of block underneath their stump. and their hip in an extended position, their pelvis flat down on the bed, ASIS pushing down onto the bed. They need to maintain this for 20 minutes every day, especially in the case of the early amputee. We can add in some extension exercises in this position by pushing the ASIS down into the bed, but we must not allow the pelvis to come back off the bed into posterior pelvic rotation. We want to have extension down through the hip and a little bit of contraction of the gluteals happening there. And in my experience, most people are quite happy for you to write a prescription for them to have a lie down for 20 minutes each day. In fact, if there's anybody out there that could write a prescription like that for me, I'd be quite happy to hear from you at the end of the webinar. If we're moving on to the more advanced situation, so we can now stretch those hip flexors a little more aggressively, we can do it with the prosthesis on in a standing position. We're going to flex the knee joint and kneel on a chair. So we're going to have some active hip stretches here with some weight bearing through that side. Kneeling on the chair, and transfemoral or transtibial amputees are able to do this stretch. We need to activate the abdominals to keep the trunk erect and avoid excessive lumbar spine extension, because we don't want the extension to be happening in the incorrect place. We don't want it here at the lumbar spine. We want it down here at the hip level. So we need to have the abs working to control that rotation of the pelvis and pelvic tilt. We don't want posterior pelvic rotation or anterior pelvic tilt. We want extension here at the hip joint. So the patient will then flex this knee joint at the front and push forwards into hip extension. And if they can activate their hip extensors at the same time, we know that activating the antagonist is going to relax the agonist at the front. So if they squeeze their bottom, it's more likely that their hip flexors will relax and allow further range of hip extension to occur, and we'll get a much more effective stretch into that hip. Once we've done our stretches, we need to have hip extensor training happening, and when we're doing strengthening of muscles, we need 15 reps, 3 sets, 3 times a week. That's what I tell my clients they need to do to start strengthening their muscles. We can start doing it even before a prosthesis is applied in this position. We've talked about this position a lot today. It's a very important one. Maintaining good pelvic control, ASI is clamped down onto the bed, and squeezing the gluteal muscles, extending the stump up off the bed. We can then do it once they're wearing their prosthesis with a TheraBand here, helping them to control their pelvis while they're contracting their gluteals and extending the prosthesis backwards. And I will get them to think about walking and visualise their walking performance. So they're going from heel to toe, and at this position he's thinking about coming off the toe of his prosthesis and pushing himself forward off his prosthesis. So if we're putting all this together, what are we looking at for the indicators of an optimal gait pattern once we've addressed flexion above the prosthesis? We're looking for even step lengths. Even step lengths and matching step lengths with the intact leg will indicate you're getting good extension over the prosthesis. We're looking for extended hips and an erect trunk. We're looking for the ability to use the entire prosthetic foot. So we want heel strike at the beginning of prosthetic stance and right to toe off, the very end of the prosthetic foot, a toe off at the end of prosthetic stance with a nice extended hip above it so that we can take a good size step with the intact leg. We've got an even arm swing happening, and hopefully lateral trunk bending will also be minimised but we will be focusing on that in further webinars down the track of the Optimising prosthetic outcome variety. That's all I've got today on focusing on hip flexion or flexion above the prosthesis.